Greetings once again. It's a pleasure to be back and it's a pleasure to be having these conversations with all of you. So, today I'm going to talk about the KMPDC memo. And this KMPDC memo is the communication that has come out as a result of the ongoing conversations around what services can be offered at community pharmacies or community pharmacies considered as primary healthcare facilities, and all those conversations that have been coming around. The interesting thing about this is there are conversations that are coming from different stakeholders and different parties, but the question is, where do we lie with this conversation? Is it about preserving our thought and looking at what is the scope of practice for ourselves, or is it about looking at what is convenient and what is ideal for the patient that we are all serving? Because at the end of the day, we are serving a patient, and that patient wants to be able to access the care they need in an affordable manner and at the most convenient of times without suffering any constraint or barriers or hurdles to that particular access. So those are critical conversations that we need to be having. So this memo came, and when the memo came was released this week, it was as a follow-up to initial communication and newspaper articles that had been doing rounds, and all that is about Britam Insurance have had a signing of an agreement with some chain of community pharmacies in the country, and these chains of community pharmacies will now be offering primary diagnosis to minor illnesses or minor conditions to patients, and at the same time being able to offer medicines to them without having to go see a general practitioner, consultant, or a physician, whatever it is. As a follow up to that, then another insurance company again also released another memo, and therefore it is now seen as a trend. And as a result of that, then the memo from KMPDC came in the different conversation platforms, including Twitter, that is X, Facebook, Instagram, WhatsApp groups that we are in. Their conversation, what are different perspectives, and everybody is presenting their opinion. The same is what I'm doing today, sharing my perspective, but also sharing my perspective from a point of what works for the patient, what works for us as professionals, but also what is the ultimate value of all these that we're doing. It is a critical conversation to have. And one of the key bits about it for me is as much as everybody's taking a stand on something, we have to acknowledge that this has been the order and the model of practice that has been in place. In the sense that if David is unwell today, David is likely to go to the neighborhood pharmacy to get his medicines and then from there pay out of pocket. If I'm going to buy every other time when I'm ill or my child is ill or even my spouse is unwell, then I'm going to definitely consider my options. Do I really have to get an insurance cover, or do I want to just pay for these out of pocket? That is a conversation that is there. Then on the other note, then for an insurance company, for me to be able to cover David to be able to pay premiums to my to our company, what would be the incentive he is able to get care? What are the bottlenecks to access to care that David has been facing? When I'm unwell and I have a medical cover, I have to go to a physician in a clinic somewhere or in a hospital. How long does it take for me to get to that hospital? Traffic within the city, that's one of the conversations. That traffic becomes an impediment. When I get to the clinic, how long does it take for me to get seen by a physician? How long does it take for me to go through the whole process and leave the facility with a prescription and a diagnosis? Then, with the prescription, am I filling it within the clinic hospital, or am I going to fill it outside? These are all bottlenecks and pain points that patients will have to go through. The risk of this is if David gets to a clinic and that is the whole chain, the next time I'm not willing to. And therefore, if I'm feeling unwell in minor kind of a condition, I'm just feeling some symptom that I'm not so sure what the condition is, I'm likely to actually just downplay that condition, that symptom. After that much as I'm downplaying it, the symptom, if it is a critical condition that might get severe, it is advancing, and therefore I'm at a higher risk of being admitted in the point when actually it's now critical that I need to go to a physician. I'll go get admitted, I'll go get advanced care and all that. So, being it's more of a severe condition and a critical care that needs to be attended to, the cost of that management is substantially higher. If I had a medical insurance, then it means the insurance company is going to pay more. Which kind of a business would it be for the insurance to want to pay more? But and the alternative is if I was able to engage community pharmacies and David goes to a community pharmacy, if he's feeling unwell and all that, maybe they'll just give me some medication to monitor. If there's necessity, I'm referred to a physician somewhere, to a laboratory to take tests and all that. And all these could happen. If they do happen, there is the convenience in the sense that the time saved, but also the issue is identified at an early age. an early stage in my progression. And at that early stage of diagnosis, intervention is implemented, and therefore the cost of that management is minimal to the insurer but also to the individual, making the whole care optimum and effective. And that is the kind of conversation. Look at it from the financial and the business perspective. Look at it from the convenience for the patient, because ultimately, in all our lines of practice, if we're looking at innovation as a key aspect, then we're always innovating for access, for affordability, and convenience. The convenience of the patient is key, affordability of the care, and access to that care. If I'm not able to access a facility, I'm not able to afford the care. If I'm not able, it's not convenient for me to go and missing work and all that, then that is going to downplay all that kind of perspective. Another thing that is critical for us to acknowledge is when the KMPDC memo came, the conversation that people are asking, does KMPDC regulate and actually register every facility that is offering healthcare services? And that would range from the community health volunteers and practitioners. Who is registering them? Who licensed them? If I'm a nurse, I'm a palliative care nurse, and I'm walking from home to home, does that home get registered as a facility, and does KMPDC does do that? Then on the other end, when I move to that from that conversation, go to the laboratory services. We need diagnostics and all that. Who registers the laboratories and the labs and all that? That is from another agency altogether. Kenya Medical Laboratory Technicians and Technologists Board, registering the professional but also the practice, including the facilities that are offering the services. Look at the nurses. Who offers nursing council? The nursing council is there to register nurses, but also regulate the practice of nursing. Whether you're practicing from homes, a nursing home, whatever kind of facility, even if it's a hospital, the nursing council has a responsibility and a mandate to oversee that. From a pharmacist perspective, pharmacies are registered as healthcare facilities and premises where healthcare services are offered, including prescription and dispensing of medicines. And that would be under the Pharmacy and Poisons Board. So then definitely then it means from the memo that came, there is a conflict in among the regulators, which are government entities. Are they conversing and engaging with each other? If not, what needs to happen for them to have conversation amongst themselves? PPB, KMLTTB, Nursing Council, KMPDC, they have to converse. But then beyond that, these are regulators regulating practice, but they are also the professionals who are practicing. As a pharmacist, as a nurse, as a physician, as a laboratory technologist, what is the scope of practice? Because oftentimes some of these conversations when they arise, it's a point of I'm protecting my foot. I'm protecting my scope of practice to be able to continue practicing and to safeguard my professional practice. It is good to protect our professional practices because when we do that, we are ensuring there's quality that is guaranteed because we know this is whose responsibility within what purview. But it also gives us value to be able to make a living out of the service that we render as professionals in that line of work, which is critical. So then the question would be, how do we ensure that we achieve all these while at the same time delivering the convenience, access, and affordability to the patient who needs it? That is a critical conversation that needs to be had. In my perspective, the first starting point for us is to acknowledge it is the order of practice. Patients get their care from pharmacies to the greatest extent. Insurance coming into that game and actually designing a solution that is willing to deliver on that is already a positive move. The question is, how do we structure it better? We structure it better by understanding what is the scope of practice. And the current conversation and the claims, even from the public, is do pharmacies offer additional services and what are these additional services? And where do we practice? We have almost 10,000 community pharmacies in the country registered by the Pharmacy and Poisons Board. Out of this number, maybe 20 to 30% would be owned by pharmacies. Others are owned by pharmaceutical technologies. Others are owned by entrepreneurs who have leased or licensed leased a license from a pharmacist or a pharmaceutical technologies. And some are also quacks running them. And that is the reality of the dynamics. So then we need to ask ourselves if we are looking at diagnosis of minor diagnoses and certain ailments that could be managed from the pharmacy level, who has the responsibility and the qualifications to be able to intervene? If it is a pharmacist, what scope of services? And this is something that is already happening in the developed markets. When you look at the US, you look at the UK, some of these practices are already in place. It's about us now refining that package of offering and seeing how do we take it to the market and where do we position it. That is important. And we have to start by looking at the scope of practice. Then ultimately, when you're talking to insurers, we can say for pharmacies that are meeting the criteria as set out by the Pharmacy and Poisons Board, Pharmaceutical Society of Kenya, manned by pharmacists with a particular set of qualifications which guarantees quality, convenience, and affordability to the patient, would be empaneled in that kind of provision. Then, beyond that, for additional services that might be necessary, what arrangements do we have in place? And that is where the regulatory aspect comes in and says, if David runs a pharmacy, David's pharmacy must have a panel of at least 3 to 4 physicians or clinics which are within the proximity, where in case there's need for further medical intervention and further medical consultation and guidance, then David can refer. If there's need for lab works and diagnostics, then David has a set of 2, 3 labs where he can refer his patients. That way, we're able to ensure that all of us are able to practice, but you're also intervening at an early point and designing an optimal solution. That is the kind of thinking that I'm looking at, and that is what I feel is going to move us forward. And one of the key things that I think as an achievement is already in place. The Pharmaceutical Society of Kenya developed the Green Cross accreditation program, and that set out the scope of what the design of a pharmacy should look like, the levels of practice that are recommended for pharmacists in different settings, and how we would expect the counseling room to look like, which means we would be pre-positioning the pharmacy to be a key integral player at the pharmacy level. And then the question is now within the primary healthcare, and this is now coming up when talking about the Primary Healthcare Act, which recently was actually signed off by the president and sent it to, and is going to be operationalized. How do we engage the community health volunteers and professionals to be funnels of care to the pharmacies, to the clinics, to the hospitals, and a referral pathway that is going to be optimal? We have to innovate, and we have to innovate to deliver value, to integrate and work collaboratively rather than competitively. If we're able to do that, I think we'll be on a different frontier, and we don't need to start fighting as we're already having conversations which are either not driving innovation, not supporting the patient, but rather safeguarding our own interests and the professional lines of practice where we want to operate within. That is going to not help us, but rather curtail growth and curtail and development, and ultimately the government's aspiration to deliver on universal healthcare coverage. I'm hoping we're able to have that conversation and see where do we change, what do we change, with who, and how do we walk it forward. That is a critical bit. If you enjoy the conversation and you find these insights valuable to you, please subscribe to the channel, like, share, comments. Let me know what you want us to discuss next. If you're willing to come and join us for the studio conversation as we keep on building on these conversations, reach out and let's make the best of it. Thank you and have a good one.